think it's interesting, Greg, as I spoke about before, he touches on the mental health aspect, and I guess we're probably doing ourselves a slight disservice tonight, only having Kim representing perhaps the mental health aspect in perhaps a small way. So I think that Tim and myself got up this afternoon. One of the things we'd like to do April next year is put together another little patient forum where we've got some ideas around talking about the mental health aspect. Certainly that weighs on a lot of the patients here, and Tim and myself often talk about it at the pharmacy. We feel that probably 1 in 2 of the blokes that come into the pharmacy is suffering from an amount of anxiety or depression around their diagnosis. All right, so let's get this thing going. So I thought tonight I'd start by asking the question, where do we start? And I think most of the gentlemen and partners here tonight have probably asked themselves that, and part of the answer to that question is coming to see the pharmacy, going to see Maureen, going to see somebody like him. So I think it's a pertinent question to ask, where do I start? So I'm just going to hand over, Tim, I'll put you on the spot first, just to get your comments as to where do you feel a patient and perhaps their partner is best to start after they've had a prostatectomy.
Ideally, we'd start prior to the prostatectomy. Often we don't catch patients at that point though, and that's in part fault of, I guess, the speed of the whole process. Sometimes you might only get your diagnosis and then 2 weeks later you've got you're on the bed of the hospital getting your prostate removed. So it doesn't really add itself to being able to go and see multiple different health professionals prior to your surgery. But if we could, ideally we'd see you a few weeks before. We'd get you started on a tablet like Cialis, something like that. There's lots of evidence in fact there's some centres in the US are starting their patients well before their surgery on medications like Cialis to protect the blood vessels to the penis and to the prostate region itself. So ideally we would get them earlier than the surgery, but that's not always the case, and pretty much it's never the case, especially in Canberra, if not Australia. So really, as soon as possible after surgery. The tablets are an easy one. You can take the tablet, obviously, right from prior surgery all the way through. The injections, it's going to be maybe 3 or 4 weeks, no real sooner than that, because you probably not going to be fit enough to be using that erection anyway. And then with the vacuum device, which we can go through all of these later as well, the vacuum device would be a similar kind of time frame to the injections as well. So really, if we could, prior to surgery, if not, which is mostly the case, 3 or 4 weeks post-surgery, sometimes if there's complications, we might start a bit later than that.
And Tim, I mean, you're talking from the viewpoint of a pharmacist, obviously, when you talk about the tablets and the pump and the needles. I think that's really good feedback, that you do actually want to make a start as soon as possible, certainly on the tablets, and take it relatively slow on the others. We'll come back to the injections later, because I know that for a lot of the patients, injections is a big one, and often you may not start them straight away. So thanks, Tim. Kim, over to you. So where would you typically see the patients, and how would you get them started post radical prostatectomy?
Thanks. I'm going to agree, actually. If we can start as early as possible, then that's the way to go. Not just in your sexual function, but in the context of, I'm sure everyone is going to agree that, the more erections that you have prior to surgery, the better the health and the outcome is from a physical point of view. But I'm also going to be looking at the quality of the relationship. How are you guys actually relating? How's that support going on between you? And can you guys communicate about, your fears and your concerns and what support that you're going to need from each other during this entire journey? Because you need each other. You've got to be able to talk about what's actually going on. And communicate, and what does sex mean to you? So again, the more we talk about all of that, the better. Typically, I think I see them, unfortunately, 2 years down the track. They often get told the advice, don't expect much for 2 years. And then by that stage, they come to me and we've just wasted 2 years. So it's so important to come and see any of us so that we can get you on track and in the system as quick as possible. Just like starting before surgery, within that 6 week, after that 6 week post-op period, we need to get you going. We need to get you on the relationship. We need to start looking at other forms of sexual intimacy that doesn't necessarily require an erection, and keep that going. So, yeah.
Kim, I think you make a really valid point. It's sort of that adage of use it or lose it, and I suspect we will actually talk about that in part as the night progresses. So the take home for me there is use it or lose it. Make sure your relationship with your partner is as robust as possible, hence getting in early if we can. Really good comments, Kim. Maureen, the urologists tend historically to be pretty good at getting patients to see their physiotherapist post-operatively. Would you agree to that point? And equally in your practice, what's fairly typical in terms of what a patient might experience when they come to see you?
I'm on the same track as everyone else. The urologists are very good at sending the patients afterwards. They have a habit of ringing me up and saying, look, I've got this patient that's having surgery next week. We want you to see them beforehand. So generally speaking, I try and do that because I know, particularly based on the research, that seeing people pre-surgery is far, far beneficial for gaining their confidence more post-surgery. Because there's nothing worse than trying to learn how to do any new exercise where you've got a complicating factor of having some urine leakage already. If you can learn how to do the exercise beforehand, it makes it so much easier afterwards. And certainly research shows it will reduce the length that it takes you to recover, with all things being equal, because all surgeries are not equal, and that's an important thing to realise, that you can, sure, everyone else's story can be a guideline, but not all surgeries are equal, and not all recovery rates are the same. But there is a bit of a general trend, and I try and explain that to my patients. And I think, again, the more information they can get before they have a surgery about likelihood of incontinence and the likelihood of its normal sort of track of behaviour as in recovery, I think the better it is for people to cope. Perhaps the less anxious they may get afterwards. And I'd just like to ask Kim, so you wouldn't see them until 6 weeks post? Yeah. But if in an ideal world, would you wait until that 6 week point?
I'd see it before.
Yeah, okay, just so I know.
100%. I'd see it before because I want to look at my expectations and communication to make sure we can do anything possible, as well as exercises and everything else, to get that function, but also the context of the relationship.
I think a really valid point was brought up there, and I'll table that as we move through the night, and that's around setting expectations. I think a lot of the patients that come through may have false expectations or they've misunderstood the advice that's being given to them by the urologist or their doctor, and that can be quite disheartening. And we often talk about compliance. I think Maureen talked about compliance before, so we'll table that later in the evening. So that's around setting goals, expectations, and how we can best help the patients. Ian, I think it's probably fair that I throw it to you, mate, if that's okay. Would you like to tell us a little bit about where you started, I suppose? Probably not so much about your diagnosis. I think we're all pretty clear on the diagnosis. You have your PSA typically, or you have maybe have a bit of an issue with the waterworks. Often it's overnight. That may not actually be related to prostate cancer. It can just be an inflamed prostate. So we're probably less on diagnosis, but perhaps more on what your experience was post-operatively. You know, they removed the catheter. Obviously, you had some incontinence. We've spoken about that before. You read out it pretty well. But I think it would be interesting to hear about how you got on after your surgery, and just to lead you, if I may, along a certain path, you had an interesting experience when you called up and seeked help. Maybe it was Jane's experience, but you called up to seek help from a support group and you were pushed down a certain track. So maybe you could share that experience.
I'd just like to say that, can everyone hear me? Do I need this? I don't need this. I think really, I can't emphasise enough what the others have been saying. We're all singing the same song, obviously, but pre-op, it is vital that you do your pelvic floor exercise. Now, I was fortunate because I was fit and I had a bad back problem, so I've been doing Pilates, so my pelvic floor was strong when I was diagnosed. But even then I had, I think, from diagnosis to the biopsy, which was awful, that was about a month, and then another 6 weeks or so until the surgery. So in that time, it became a second religion. The pelvic floor was every time, all the time, every day, several times a day. And by the time I had my surgery, it was as strong as it could be, and I had no continence problem whatsoever. Now that's unusual, I understand, but what I can say is that from others I've spoken to, if you have jump on it straight away, or if you don't get the opportunity before, certainly afterwards, treat it like a religion, like your seatbelt. Put it on every time you sit down, do a pelvic floor. 7-8 times a day, short numbers of repeats. Well, that's what I was doing, and it really helps the incontinence, if you have it, to recover and to dry up a lot quicker. That was my experience. I'm going to disagree with you.
I'm just going to say that, and as I said before, not everyone is the same, and it's a small muscle and it can fatigue. So everyone's a bit different, so don't necessarily do what everyone else does. It needs to be tied to your ability at that time. That's all.
Yes, please, Jane.
And I know everybody here is post-prostatectomy, but if it's going out to people who aren't, going back to the pre, I think that patients go in and see their surgeon and they're given a diagnosis and they're told they have cancer. And that is such a shock. And the surgeon's keen to get in there and do something about it. And that's why I think it's so important if we have other people like physiotherapists, pharmacists, psychosexual therapists who can talk to people pre-operatively, because what you do then and the way you approach the surgery, I think will result in what outcome it is. So we read a lot, we were given lots of handouts. Ian was particularly worried about sexual function the whole way through. The morning of the surgery, he was lying on the table and he said, I'm not going into that operating theatre until somebody tells me that Dr. Rajikuna has written nerve sparing on the bottom of the thing. So it was very important, but we got very little information at that stage. And expectation-wise, probably the most shocking thing is for a man, and I've never had an erection as far as I know, but the most shocking thing is that men after surgery like this, they wake up and they're instantly impotent, and that is psychologically, I've seen with Ian, just such an incredible thing that if we had some information from experts who say, okay, now this is what's going to happen, and we read up about it, and we talked to our surgeon about it, and it was, yes, well, it's likely that this is going to happen, but in fact it happens instantly. And I think it would be really helpful to have some experts to help you along that expectation path at the beginning.
And just picking up on that, there are two areas I found where the mental aspect hits hardest. The first is one Jane just mentioned, where it's gone, literally gone. And then in your recovery, as time goes on, they're usually, I think, from what I've spoken to people about, there comes a time when you think, I'm not getting anywhere. Nothing is really improving or continuing to improve. And that's where the second hit comes. You tend to think, am I wasting my time doing these exercises? Am I wasting my time taking these tablets? Am I wasting my time trying to inject things into me when I don't want to be anywhere near an injection? That's the second level I found anyway, and others I've spoken to have found that hits you mentally. And again, picking up on Jane's point and Kim's, if you can have that talk beforehand, if it's possible, for those out there who haven't yet had surgery, get in there and you do then learn what you might expect. And then, if it happens, who you can go back to straight away, you don't have to hunt round to find out what help you can get quickly.
Thank you. I will. So there's a lot of support out there, and I think that that's really wonderful. And you know, patients will accept it, and some of them won't. And that might be support through the pharmacist, it might be through Kim, it might be through Maureen as a physio, it might be through an exercise physiologist, the GP, the urologist, or a patient support group. I'm just going to answer the question for you. So Jane, I think it was, called up and to get advice, to get support for Ian, I think it was, and the person on the other end of the phone said, "You're calling up to get help on incontinence." And Jane said, "Well, actually, no. I'm wondering about getting some support for erectile function." And I think, you know, in our practice, we have to talk about the big ticket items. Big ticket items, getting rid of the cancer. Number one, we can't live with the cancer. That's got to go. That's got to be fixed. Or it's got to be medicated if you're on ADT or androgen deprivation therapy. So that's got to be managed or removed. If it's removed, then the next big ticket item is invariably continence, and perhaps of equal weight, but men might not tell you that, is erectile function. And we see men from early 40s. We've got a gentleman who went under the knife a week ago who's early 40s at the moment, and the conversation with him is different. It's about putting sperm in reserves, and what's he going to do with that? So he's got a new partner, so there's all those sorts of conversations. So you know, making sure that we get the right advice to the people is really important. So the three big ticket items: getting rid of the cancer, making sure that we've got incontinence under control, and probably an equal weight erectile function, with the erectile function often sort of slipped under the carpet because nobody's brave enough to say anything about it. I guess on that note, I might take a thread out of that. Tim, do you want to just tell us a little bit about what you see in the pharmacy around erectile function outcomes? Put you on the spot a bit there.
Outcomes in terms of blokes that we've seen?
Yeah, I think in our practice, yeah, that's right.
Yeah, so there are certainly blokes that we get in for that first appointment. We go through everything. They might seem like a deer in headlights, which often is the case. But they'll take everything home. They'll go through things. They might last a couple of weeks. They might hit that first hurdle, which might even be, 3 or 4, 6 months down the track, and then they'll stop. We've also got guys that'll, go the whole shebang. They'll do everything as prescribed, exactly as prescribed. They'll even do it at the same time of day, every day, and they'll go down that track as well. They might hit a speed bump, but with our support, they'll kind of continue going, hopefully. And then we've got blokes that generally just don't do anything. So we do get the whole spectrum of blokes going through this rehab. I have to say that the ones that are able to fit it in their daily routine, the ones that stick with it, as you guys have, they generally get the better results. There are only a few things that are going to affect how you can recover or how you will recover your erectile function. One of those things is age. You're not going to change that. One of those things is your type of surgery, so whether it's nerve sparing or not. If you've got no nerves left whatsoever, well, there's no chance of getting your function back. The third thing is, your other health conditions, I suppose we could put it. So, if you've got quite advanced diabetes or other health conditions like Parkinson's, so on, then you have less of a chance of regaining your function. You can't really control that. Yes, you might be able to control your diabetes or your blood pressure a little bit better, and that might help you to recover a little bit better. But really, the only thing you can control out of all of this is your rehabilitation the protocol that you're prescribed by your urologist and helped through by your pharmacist or your physiotherapist, your psychosexual therapist. That protocol is really the one thing you can control. And if you can do that, or if that's that one thing, your mental health, yes, absolutely. So mental health you can certainly control with help too. So if you can take control of those things that you can and forget about those things that you can't, you're much more likely to put yourself in the best chance possible, I suppose, of getting that function back.
Yeah, bravo. I think that's quite right. And as Kim rightly points out, the mental health aspect I think is something else that we can actively work on. Maureen, just to throw to you from an incontinence point of view, because there will be a number of blokes in the room for which incontinence is an ongoing issue. What are some general expectations that you would set around incontinence in terms of duration of perhaps the incontinence? Like, will it improve? And yes, each patient's journey will be different, but at what point do they say, right, well, I'm doing the exercises and it's not particularly working? At what point do we then progress them to the next option, which might be going back to the urologist or changing the exercises or seeking further advice? Are you able to talk about that for me?
I'll start with some just general guidelines. I mean, urologists will unlikely to do anything to help continence until you're at least 12 months post-surgery, because they understand that there is a long recovery period. And it's not a straight line. I have this wonderful little chart of work that says recovery can be like this, but it can even be like this. So it's never a straight line. And you will, as you mentioned, you will get those plateaus where you think, I'm doing everything I'm supposed to do, but nothing's happening. But as a general rule, you'll get some improvement at about the 3-week point, some improvement. You'll get more improvement about the 6-week point, and that relates to the initial tissue healing post-major surgery. It's great with robotic surgery. These little cuts on your skin surface, they heal up, they're great at 3 weeks, they look fantastic. Well, guess what? Inside, it's definitely different. So it takes longer for the swelling, internal swelling, to be reabsorbed, and for any irritation that might cause to the nerves internally and other tissues to settle down. So really, in that first 6-week period, just take it step by step, day by day. Do your homework and touch base with your physiotherapist or whoever you see. And percentage-wise, I think a lot of people will be very much more confident by the 3-month point. I had a privilege of sitting in on a conference nurse over in WA who had vast experience when I was doing my studies. And she said to her men, give me 3 months of your life before you get back to a lot of your normal activities. So I think that's an initial expectation, that really you're having to think about this for 3 months. Now the other thing that I think is important is that if you wanted to rehabilitate your biceps or your calf, it's actually going to take you more like 5 or 6 months to get a significant muscle strength change. And in some ways that's what we're looking for from your pelvic floor muscles. We need it to get bigger, bulkier, we need it to improve its endurance, and that doesn't happen overnight. There wouldn't be all the gyms in the world if these things happen overnight. So you really, I say to people, really, you're going to keep improving steadily if you're diligent with your exercises over that 3 to 6 month period. Is that answer what you had in mind?
Yeah, it does. Yep.
If people have got questions as we're going through, I think you should ask them at the time. Because if you're like me, you're going to forget your question, and then you'll think, oh, why didn't I ask that?
Maureen?
Yep.
Yes, fortunately I was able to attend to you, and as you said, it was back in February I had my operation, and it worked very well. By the way, I don't think much of your legs, Brad. Look at
No comment.
I did very well, as you said, after the 6 month period, but the problem I face now, and I stopped doing my exercises, is when I cough or sneeze, or sometimes get into an awkward position where I have to lift something heavy, I might dispense a few drops. So I'm still going to wear my pads, when I'm out and about during the daytime. Is there any, do you continue to do the exercises for that? You should do.
Yes. Yes. We could all be doing them now.
Absolutely. It's the exercise you can do and no one's doing it. Yeah, anybody in the room, whatever sexual. Those points you mentioned are very specific. They relate to you using your abdominal muscles strongly, you're generating a downward pressure, and the pelvic floor strength can't quite cope. Now, what I would say to you is, have you remembered to tighten your pelvic floor before you do those activities? So that's the sort of thing that should become an automatic habit, but it takes at least 3 months. It's like retraining your brain for anything. It takes 90 days apparently. And that's what you've got to focus on. And I say to people, look, you all know when you leak, so you need to focus on tightening that muscle when you cough, bend awkwardly, or sneeze. You may not need to worry about that because
That's
no
just started
problem.
dawning on me just the last couple of weeks.
Yeah, okay.
It's just started triggering.
Right, that's fantastic, yeah. Yeah, and everybody's a little bit different, so eventually I say to people, look, if you leak, repeat that activity immediately and try and stop that leak, because then you're targeting your pelvic floor to your problem, not someone else's.
Just a quick question while you're talking about all the inflammation and thing that happens post-operatively. Does that affect the bowel as well? Do you get a whole lot of issues with the bowel?
Not necessarily, no. Yeah. I've had very few patients that have had, sorry. I have had very few patients that have had significant bowel issues. Now, that will depend a lot on what your condition was beforehand. Like if people have pre-existing bladder or bowel conditions, that does impact on your recovery. So if you do have a bowel condition, certainly the pelvic floor is a significant part of that too. And your diet and managing your, this is a good question while you're all eating, managing your stool type. So if you've never seen a Bristol stool chart, you haven't visited me.
I'm not talking about incontinence, I'm talking about graft, muscle, you know.
Yeah, the pelvic floor muscle.
No, in the bowel.
Oh, the muscle in the bowel itself.
Yeah, that graft.
That muscle is a muscle you don't have conscious control over. It's what's called a smooth muscle. So your bowel movement, sure, I think it gets impacted on at surgery. I can't see how it can't because they're pushing it out of the way. Yeah. So I think that does take a little bit of time to recover immediately post-surgery. Sorry, I misunderstood your question.
That's okay.
Yeah.
I'm not sure if anybody's immediately post-surgery here, but I think it is worth noting when you've had any abdominal surgery, you've got to be very careful what laxatives you take. Always ask your pharmacist or doctor if you're not sure what laxatives to take, because you can actually do yourself some damage by taking stimulant laxatives. There was a question also.
Thanks, Brad. Another question is there any information available? Is there an average time from when you've had the operation to when you may get erectile function back again? Is there any statistics or information on that?
Tim, would you like to field that? Oh, Kim? Yeah, no, Kim, you go, Kim, and then we can pass it to Tim.
Look, I think it's really individual, and it's going to depend on the surgery and their approach and whether it's nerve sparing or not, and how much nerves they're actually able to get. But don't expect something straight away. But I would be saying that, you know, if you've got very, very good nerves being kept intact, then something should be happening sort of around that, in that first 3-month period, you know. But having said that, don't get stressed if it's not. We just have to keep doing those exercises. We're going to have to do that. We're also you're going to have to go and see somebody about other types of exercises as well. I don't know if I'm allowed to talk about that.
About other exercises? Go for it.
Yes, Kim.
Yeah, well, go for it.
That's okay. I don't want to upset anybody, you know.
No, not at all.
Okay, so if you have a partner and your partner's very, very happy to, you know, lend a helping hand, we need you guys to do it. It is really use it or lose it. Don't start after 2 years and go, well, now I'm going to start doing something. In the event that perhaps your partner doesn't choose to want to get involved at that time, or maybe later, or isn't quite sure, you know, any of this stuff, well, then you're going to have to start looking at doing this solo. You need to spend time, like any other muscle, rehabilitating your erectile function. Okay.
So just a personal anecdote, we've got a number of patients that come to us once or twice a week and we assist them with their injection. So Kim talks about the idea of use it or lose it. There's a good number of blokes out there that they might not be sure about how to do an injection, or they might not be comfortable doing an injection, but the concept of use it or lose it is really important. And there's a good number of blokes that do fly solo for a number of reasons. So their partners are often unwell. They might be uncomfortable. There's a whole lot of things that can impact on a chap's ability to engage with with their partner. And we see blokes, same-sex relationships with females, and it can be very different for everybody. So I think Kim's point is correct, use it or lose it. Tim, I'd be interested to hear your thoughts on the recovery. I know we work towards certain timelines. Would you like to elaborate on that somewhat?